Good morning, dear colleagues. My topic, my PhD, is maxillofacial surgery in cleft lip and palate patients. I am Alexander Schulze Wenning, currently a second-year PhD student here at the Translational Medicine, as well as a fourth-year dentistry student here at Semmelweis. My vision is to increase healthcare accessibility for patients with cleft lip and palate, or to phrase it in a different word, no cleft baby left untreated worldwide. I want to achieve this by reducing the invasiveness through research-based clinical decision-making. And I would like to achieve this both by my two specific goals, the second one not being that much about cleft lip and palate, but a third and the fourth one will come about cleft lip and palate. So my first topic is basically a comparison of two types of philosophies, philosophy of surgical approach. There we have the one-stage surgery and the two-stage surgery, both surgeries for palatoplasty, and we look for the outcomes for maxillofacial growth and speech. So far for my first manuscript, we have, it is now under review since September the 23rd, so roughly 7 weeks, and we hope to soon get a positive response in the Journal of Cranio-Maxillofacial Surgery. Yes. So, cleft lip and palate. Cleft lip and palate is the most common facial deformity with a worldwide incidence of 1 in 600 live births. And an astonishing number, this is even much, much higher in Southeast Asian countries, such as Thailand, Indonesia, where it can be up to 1 in 250 live births. It results embryologically from the non-fusion of the alveolus, lip, soft and hard palate, as you can see here. And then depending on what type of cleft we are dealing with, also, of course, different parts which have not fusion. The most common version is the unilateral complete cleft lip and palate, left-sided one. Yes. One of the main reasons for this research is that it was shown in not long ago that there are no universal guidelines and that 201 different cleft teams in Europe operate in 194 different protocols. That's why we wanted to find out which protocol is really the best for the patient concerning one-stage or two-stage. These are the main overall protocols. So, one-stage surgery is assumed to result in better speech development since an early closure of the hard and soft palate will enable the tongue to learn and to interact with the palate properly and also then result in a better and more natural speech development. Controversy to this, the opponent or the opponents of two-stage surgery believes that two-stage surgery is better because apparently a better maxillofacial development can occur. Since later suturing of the hard palate would lead to a later scarring, and later scarring then decreased risk of prognatic maxilla. Yes. So that's why we set out to investigate if patients benefit more from one-stage or two-stage palatoplasty. Oh, of course, do patients with complete cleft lip and palate benefit more from one-stage or two-stage palatoplasty? The patients were patients with uni and bilateral cleft lip and palate. As intervention, we had one-stage palatoplasty, which we then compared with two-stage palatoplasty. Yes. Also, as the outcomes we looked for, as I said, maxillofacial development and speech outcome. Mainly for maxillofacial development, for cephalometry, hypernasality, cephalometry. These are the maxillofacial parameters, and a secondary, we have anterior crossbite, velopharyngeal insufficiency. Our hypothesis is that one-stage surgery, one-stage palatoplasty, has the same or a better clinical outcome than two-stage. If this would be true, we could increase the amount of operative cases, and this is one of the main reasons for it. And these are especially in operative cases in third world countries and developing countries where not yet every baby has the opportunity to receive such surgery. If we can prove that one stage is at least as good as two stage, we could decrease the amount of surgeries performed, while this increasing the amount of surgeries for each, for overall kids which are operated. Further, also, it would cause a decrease in anesthesia exposure for these young kids, which is especially in this young age very important for neurodevelopment. This was our systematic search done in October 21. The search key, as you can see, in 3 databases. We ended up with 36 full-text eligible articles. The first outcome which I would like to present to you is the U1PP angle. It is the angle between your upper incisor and the palatal plane. This is a very important factor or angle, especially for the soft tissue aesthetics in the face. Here we can see, or it was shown, that we have a statistic significance favoring the one-stage approach. The second outcome which I would like to show you is the velopharyngeal insufficiency. Velopharyngeal insufficiency means the capability of your soft palate, the velum, to properly close against the back wall of the pharynx. Also, this is very important for cleft lip and palate patients, but especially more for speech outcome. Since if your velum can't properly close the oral cavity to the nasal cavity, it can happen that air is escaping through the nose while you speak, and overall would decrease the quality of your vocal speech. Also here we could show that there's statistical significance favoring the one-stage approach. The next outcome, hypernasality. Also here a very crucial parameter for the speech development of the kids. Also here we could show that there is no statistical significance, but we could see there were a clinical significance, since for most cases the events of a severe hypernasality was less common after one-stage surgery than a two-stage surgery. The next outcome is about cephalometry, which I said before, about the maxillofacial development mainly. Here we have the SNA angle, the sellar nasion A-point angle. This is mainly the skull of the base of the skull to the A-point, which is the most concave point of the maxilla. So this is also the outcome with the most data parameters which we could gather, and which is for sure one of the most important factors, especially in the palatal development. Here we can see a retrognathic and a prognathic maxilla. So we could show that there is no tendency favoring either one method over the other. With this, also supporting a one-stage approach. As I said and explained before, if it's as good as the other, it is enough to do one surgery. The next outcome, anterior crossbite, also a very important factor and very interesting for dentists here with us. Also here we could show no tendency favoring one method over the other. As a conclusion, one can say maxillofacial development does not differ substantially between one-stage and two-stage surgery, but one-stage surgery provides better speech development. So, as an implication for practice, one-stage surgery is the operation of choice for most cases, but for sure we need more studies. More studies should be done, especially describing more in details and more in depth the timing, but what will also be very interesting to have a study which are much more in detail about the width of the cleft. Yes. As a quick summary, the strengths were, of course, strict adherence to the PRISMA guidelines. It is the most comprehensive up to date, and it's the only study comparing multiple outcome variables together, as I said, maxillofacial development and speech development, and the only study with subgrouping in this form. Unfortunately, there were no RCTs due to the nature of disease, only retro and prospective study design, and unfortunately, due to high operation, huge amount of difference in operation techniques, we have also a high heterogeneity. Let me introduce you my second topic. It's a proof of concept meta-analysis investigating the clinical applicability of salivary microRNA as an early cancer diagnostic factor. So, over the last few decades, cancer diagnosis as well as treatment has improved many, many folds. But why is cancer still one of the leading causes of death? It's mainly because early detection is still lacking behind. Early detection might happen by accidental findings, or it's not early anymore if you already have symptoms and then it's found. So early detection is one of the most crucial parameters to combat and tackle cancer in our world. So we already know from research from last year that blood plasma microRNA is an acceptable early tumor diagnostic marker, theoretically. But why are we interested in saliva? Saliva is much better than blood. For saliva, we need no specialists to draw the saliva. Everybody can just spit in a tube. There's zero risk of infection for the practitioner as well as for the patient, and it is much more accessible for everyone. Further, research from last year has shown that cancer-specific microRNA expression patterns are found in the saliva, and with this, it's even possible to determine the origin of the primary tumor. Further, also research from last year has proven that microRNA is stable and abundantly found in saliva and within exosomes. So those, That's why we set out this clinical question and our question framework as a PERT model. Is salivary microRNA an applicable early tumor diagnostic marker? We look at all patients with cancer and also at healthy control patients. The index test will be salivary microRNA, and we'll control this with clinical diagnosis, histopathodiagnosis of known cancer. Then, of course, sensitivity, specificity, everything for a diagnostic matter. Our hypothesis is that saliva can be used in early tumor diagnosis, so it has a minimum specificity and sensitivity of 0.8. With this, we could enable early targeted treatment accessible for everyone. This was our search key done this October with these results. In the end, 28, 31, because we had 3 articles in not English, so we still try to get them. 2 were Chinese and 1, sure. Yes, this is how far we are done. So for 70% data extraction is done for all of them. Also the risk of bias, yes. That's what about my second study. Thank you all for your attention. With the words of Walt Disney, if you can dream it, you can do it. Thank you very much.
Thank you very much again.
Thank you.
Alex, I'm considering with the second topic that you investigate the patient with cancer and the healthy patient according to early tumor diagnostic marker. How can you explain to me, or for the dentist, how can you manage early diagnostic tumor marker patient with cancer?
Absolutely right. Thank you very much for your question. It's a very good question. So the point in this is, of course, it's more difficult to say early cancer, early tumor diagnostic marker. So what we have done, or what's in the studies we included, they have patients, let's say we have 50 patients, and from 25 they know they have cancer, and they have early stage cancer. So they're known early stage cancer, and the other 25 were checked, and they have 0 cancer. And now we check from all the 50, the microRNA in their saliva, and if we can see there is a difference between the 25 who are already histopathologically diagnosed with early cancer and the others who are known to be healthy, then we can see if it's acceptable or applicable as an early tumor diagnostic marker.
Then I suggest you modify the P in PICO, so the patient with early cancer.
Patient with early cancer.
Maybe.
No, makes sense.
Thank you very much.
Thank you very much.
Do you have any question?
Thank you. It was a really nice presentation. For the first topic, can I ask whether, have you seen that there is, what kind of, financial stuff? Is there any difference between the two methodology, and in which way?
Methodology mean 2 types of surgery, right?
The 1 stage and 2 stage.
Of course. So as you could imagine, 1 stage means we only have 1 surgery, and 2 stage is that the palate, hard and soft palate, is divided into 2 surgeries, either operating first the soft palate or the hard palate, or vice versa. And if you have just 1 surgery, of course, this would be much cheaper for overall health costs. So also this then further underlying the importance of 1 stage surgery, especially for third world countries and developing countries. If a patient only needs to be hospitalized once, and also the aftercare is only once, so also this healthcare system can save much more money in 1 stage compared to 2 stage.
This might also happen in lobby work.
This
was logic for first, but there may be hidden stuff what I have not seen.
No, but thank you. It's not. It's not.
Thank you. Thank you.
Congratulations for your work. Regarding your first project, you mentioned that it's more common in Asia.
Much more common in Asia.
What's the reason behind it?
It's still under investigation. What we can say is Nordic countries, such as Norway, Sweden, they have much less. It's about 1 in 1,200, 1,300. In overall worldwide, 1 in 600, as I said. So it's a multifactorial disease. There's definitely genetic input in it, but also probably some kind of environmental factors. But luckily, we have 1 student in the first year who's investigating exactly this question, maternal risk factors for the development of oral facial clefts. And hopefully we'll know more in the end.
Thank you very much.
Thank you very much, Alex.
Thank you very much.